Hey guys, in this video I'll explain you about internucleal ophthalmoplegia. So INO is the most confusing topic from ophthalm. So we usually tend to confuse which sided adduction weakness is there, which sided abduction nystagmus is there, and what is actually INO, which structure is involved. So they ask you questions related to these confined zones of this topic. So let's get started now. Firstly, I'll try to explain you about the frontal eye field, PPRF, MLF, lateral rectus, medial rectus, the pathway of movement of eyeballs. So let me draw a simple diagram for you here. So whenever you have to move your eyeballs to one side, like both the eyeballs to one side, let us suppose in this image you want to look towards the right side. So whenever you have to look towards the right side, just imagine it with your own eyes also, like you do the movement with your own eyes so that it will be easy and you'll retain this topic for longer time. So when you have to look towards the right side, so in this representation here is the right side and this side is the left side. Okay, so when you have to look towards right side, the right lateral rectus muscle is used and the left medial rectus muscle is used, right? So these are called as conjugate muscles, right? The two muscles which are used for the same sided movement are called as conjugate muscles. So when you have to look towards your right side, you have to use your right lateral rectus muscle and the left medial rectus muscle. This is more like a tongue twister topic. So yeah, right lateral rectus and left medial rectus are used when you move your eye towards the right side. So in order to have this movement conjugatedly, like in order to have this movement smoothly, you should have a pathway which keeps both movements intact. So that is what is MLF. So firstly, try to understand that this is the brain cortex. Okay, let me highlight that for you. So yeah, this is the cortex, cerebral cortex, in which you have this frontal eye field. So this frontal eye field of the contralateral side. So let us suppose you are sending the signals towards the right eye. Then your left frontal eye field gets activated, like it sends the impulses. So your left frontal eye field sends the signals towards your right parapontine reticular formation. So PPRF is parapontine reticular formation. Left FEF, frontal eye field, sends the signals to right PPRF, and this right PPRF sends the signals to right-sided sixth nucleus. So this is the nucleus. It sends the signals to right-sided sixth nucleus, and that sixth nucleus sends the nerve, it is the sixth nerve, to the lateral rectus. So we know the mnemonic of SO4, LR6, and rest all extraocular muscles by reverse of E is 3, third now, right? So all extraocular muscles, superior rectus, inferior rectus, etc. by third now, whereas LR is by 6, that is lateral rectus is by 6, and SO, that is superior oblique, is by 4. So the muscle under discussion for us now is LR6. So look at here, sixth now sends the impulses to the lateral rectus on the right side. So that causes the movement towards right side in right eye. Okay. Now this sixth nucleus here is connected to the third nucleus of the opposite side. So the right sixth nucleus is connected to the left third nucleus via a tract. That tract is called as MLF. That is medial longitudinal fasciculus. This is the most myelinated tract. So medial longitudinal fasciculus passes the signals from right-sided sixth nucleus to the left-sided third nucleus. So you name the direction of that MLF, or you name the side of that MLF based on the third nucleus to which it is supplying. See, it is starting from sixth nucleus right side and ending at third nucleus left side, right? So you have to name it according to the third nucleus name, which is left. So the MLF which connects right sixth to left third is called as left MLF, whereas the MLF which connects left sixth nucleus to right-sided third nucleus is named as which MLF? It is named as right MLF. So remember that point. So MLF is always named on which third nucleus it is ending at. So here it is ending at left third nucleus, so you have to name it as left MLF. So once again, let me summarize this for you. So yeah, let me highlight it in different color. This is an important pathway. If you understand this concept, you'll answer any question on INO easily. So that's why I'm taking time here. So left FEF sends signals to right PPRF. This right PPRF sends signals to right sixth nucleus. From the right sixth nucleus, MLF carries the fibers to left third nucleus, and that MLF is named on this left, that is left MLF. And this sixth nucleus carries the signals to right LR, and the third nucleus here carries the signals towards left MR. So these two are the conjugate muscles. LR and MR are the conjugate muscles which are kept intact by left MLF. So this is what is the pathway, the actual pathway. Now let us suppose that there is a problem in MLF zone. So let us suppose this MLF function is lost. This MLF is lost. So there is some problem, some damage has occurred in medial longitudinal fasciculus. So now you try to analyze yourself, like what happens. The pathway till here is safe, right? Till the sixth nucleus it is safe only. But from the sixth nucleus, the impulses that are needed to be carried to third nucleus are hindered. And so the third nucleus sending impulses to MR is also hindered. So what happens is, this pathway is intact. From FEF to PPRF is intact, and the PPRF to sixth nucleus is intact. Sixth nucleus to LR is also intact. So what happens is, right-sided abduction is normal. Okay, so right-sided abduction is normal, whereas left-sided adduction is gone. Left-sided adduction is gone because medial rectus is for adduction movement, whereas lateral rectus is for abduction movement. Right? That everything, all of us know, that is the basic point. MR is for adduction, LR is for abduction. So the left-sided adduction is gone and the right-sided abduction is gone. So this is happening when left MLF is lost, right? So that is what I have written here. Whenever an MLF is gone, you call it as INO. Okay. So let us suppose left MLF is gone. That causes left-sided adduction weakness and right-sided abduction nystagmus, because the right-sided abduction movement is normal. So the eye tries to move towards this side, like lateral rectus is functioning. But since the medial rectus is not functioning, more of the impulses comes towards this lateral rectus, causing the nystagmus, abnormal movement. So more of the innervation comes towards the lateral rectus, since the conjugate muscle, which is medial rectus, is not having any impulses. So that leads to nystagmus. So whenever they ask you about INO, they usually ask you about which side adduction weakness is seen and which side abduction nystagmus is seen. So I have summarized it in one single point for you. So whenever an MLF lesion is seen, it causes ipsilateral adduction weakness and contralateral abduction weakness, abduction weakness. So in our example, that was left MLF, that causes ipsilateral, that means left-sided adduction weakness. Look at here, left-sided adduction weakness, and contralateral, that is right-sided abduction weakness. See, right LR is lost, right? So right-sided abduction weakness is seen in left MLF lesions. I think I have explained the pathway in a neat manner. I hope you understood this. Now let us look at the eye images. Okay, when a person is suffering from INO, like when the MLF lesion is seen, so when you ask the person to look straight in the center, the eyeballs are in the normal position, both right and left. When you ask the person to look towards the left side, he looks normally, like left here he is looking normally, like left-sided lateral rectus is good and right-sided medial rectus is also functioning, right? So left LR is okay and right MR is okay. Now when you ask the patient to look towards the right side in this direction, here the right LR is okay, functioning, but the left MR is not functioning. The eyeball is in the midline only. It is not moving towards the medial side. Towards the nose, it is not moving. That is, adduction movement is lost. So here you interpret that left-sided adduction movement is lost. So that means left-sided MR is not functioning, whereas right-sided LR is functioning, but you see the nystagmus. In the question they mention you whether the nystagmus is seen in right side or not. So here I am telling you that there is a nystagmus in right eye, but the lateral rectus is moving properly only with more innervation, whereas in the left side the medial rectus is not functioning, so there is adduction weakness. So here you can conclude that this is left MLF lesion because ipsilateral adduction weakness and contralateral abduction nystagmus, right? So this is left MLF lesion. I hope the point is clear now. Whenever there is a lesion of MLF, you call it as internuclear ophthalmoplegia. Now, in that we have made a video on brainstem syndromes. Like, please do watch it, guys. It's so very important for both NEET and inicet. So in that brainstem syndromes video, I have told you two syndromes which is related to this INO pathway, which is related to this MLF pathway. So one syndrome occurs when there is a lesion in PPRF zone, and one syndrome involves the MLF lesion. So the PPRF lesion, one is F for F, that is Fovey's syndrome, which is a Pontine syndrome. Fovey's syndrome has this PPRF involvement, so that's why this conjugate gaze palsy is seen in Fovey. I hope you remember. If you watch that video, you will not forget this point, that conjugate gaze palsy is seen in Fovey's syndrome. Now I have explained in detail that when the PPRF is gone, see this, if PPRF is gone, the whole pathway is gone, right? Like there is no movement at all in both LR and MR. So that's why the conjugate movement is lost. Whereas if the MLF lesion is there, that leads to INO. And this is seen in which syndrome, guys? This is seen in medial medullary syndrome, which is otherwise called as Dejerine syndrome. So medial medullary syndrome is associated with EMS, right? MLF, whereas Fovey is associated with PPRF. So I just thought of revising that point for you, which is important. So yeah, this is regarding INO. Now let us understand the etiology of INO. So the causes of INO that you need to know are, in children it is tumors, and in adults it is demyelination disorders like multiple sclerosis, and in elderly it is stroke. That's just a factual point: tumors, multiple sclerosis and stroke. There is one more term called as pseudo-INO, guys. So this is called as pseudo because there is no lesion in the MLF as such, but the same symptoms occur. Like the eyeball movements are like similar to the INO lesion only, but there is no lesion in the MLF. So the example is myasthenia gravis and Miller-Fisher syndrome, which is a variant of Guillain-Barré syndrome. So myasthenia gravis and Miller-Fisher syndrome are the examples of pseudo-INO. I think this topic is clear now, the INO points. So yeah. Now let us understand few important terminologies here. So WebINO is, this was once asked in inicet. So WebINO meaning W for wall, E for eyed, B for bilateral INO. So wall-eyed bilateral INO is WebINO. So that means in both the eyes, that means two MLFs are affected. That is, right MLF is affected and left MLF is affected. The eyeballs finally have this abducted position in both the eyes. That is the image of WebINO. Coming to the 1.5 syndrome, this is another important syndrome that they usually ask. So 1.5 syndrome meaning there is a lesion in MLF as well as PPRF of one side. So please concentrate here, guys. You might get confused. I'll try to explain you in a neat manner so that you don't get confused here. This is the most sensitive or delicate zone where people get confused. So let me explain you. 1.5 syndrome is the lesion of MLF and PPRF on one side, right? So in this image, so yeah, look at this. Let us suppose there is lesion on the right sided PPRF and right MLF. Okay. So now the lesion is in right PPRF and right MLF. Do not mark MLF based on the location, guys. Mark the MLF always based on the third nucleus which it is supplying at the end point. Okay. Now in this diagram, the left sided frontal eye field is sending the impulses towards the right sided PPRF, and the right sided PPRF is sending the impulses towards the right sided sixth nucleus, which supplies the right sided lateral rectus LR. Now, from the sixth nucleus, you have this connection towards the third nucleus, which is called as MLF, medial longitudinal fasciculus, but that is named as L because it is supplying the left third nucleus. So, our discussion is regarding 1.5 syndrome. So, you have to concise with right PPRF and right MLF. You should not talk about left MLF here. So if the right PPRF is gone, the impulses to this sixth nucleus is gone. So the LR function is gone. Since the sixth nucleus impulse is gone, it cannot send the impulses towards the left-sided third nucleus. So this function is also gone. So right LR function is gone and left MR function is gone. Now one more thing that is involved in 1.5 syndrome is MLF, right? So right MLF is gone. So what is the direction of impulse transmission in MLF, guys? So see here. Let me label it with what color? Yeah, black. So see, what does right MLF does? The right FEF sends impulses to left PPRF, and the left PPRF sends impulses to left sixth nucleus, and the left sixth nucleus sends the impulses to the right third nucleus via the right MLF. So this direction the impulses are seen in right MLF, right? From the sixth to the third. So here you are having the lesion at right MLF. So the impulses cannot pass from this sixth nucleus towards this third nucleus. So this MR is gone. But this is intact only, no? This up to here, the pathway is intact. There is no lesion. So since the pathway is intact, the functioning of LR is seen. That is left LR functioning is seen, but left MR function is lost because the right MLF is lost. Please don't confuse with right and left. I'm trying to explain it very like consciously, like not to pronounce any word wrongly. So please try to understand. Here the right sided LR and MR are gone and the left sided MR is gone, whereas LR is intact. So I have written this whole scenario in one single sentence, that whenever you have a lesion in right PPRF that causes right sided sixth nucleus lesion, and that causes right sided LR dysfunction, and left sided third nucleus which causes left sided MR dysfunction. And when the right MLF is gone, right MLF, see here, right MLF is gone, that causes right INO, which means right sided adduction weakness. So right sided adduction, meaning adduction muscle is MR. So right sided MR is gone. So only muscle which is functional is left lateral rectus. So left lateral rectus is the only muscle spared in right sided 1.5 syndrome. Similarly, like oppositely, when the left sided 1.5 syndrome is given in the question, then right sided LR will be spared. Okay, so only left lateral rectus is spared in right sided 1.5 syndrome. So this is the image which is representing 1.5 syndrome for you. So see guys, I have written this statement which is applicable when you solve this question. So structures involved are ipsilateral and contralateral third node. See, in our example it was right 1.5 syndrome, right? So for right 1.5 syndrome, right sided and left sided. See, right sided and left sided third nucleus was involved, right? That's why both MRs are gone, right? So that is what I have written. Right sided and left sided third is gone, and right sided sixth is gone. See, here right sixth is gone, that is right lateral rectus is gone, whereas left lateral rectus is spared. The structure spared is contralateral sixth, that is contralateral lateral rectus. So if you have to remember, if you have to, this is actually a conceptual thing, but if you want to save time and remember things in a single statement, so for 1.5 syndrome, the thing that you need to remember is highlighted here in the cloud, that is structures involved and structures spared. For the INO, this point you have to remember: ipsilateral adduction weakness and contralateral abduction weakness. So that makes the job easier for you while solving the questions. So let us look at the eye images here. So now when you ask the patient to look normally, like in the center, the patient left eye, see, the patient's left eye is in the abducted position because the left lateral rectus is paired, right? The left lateral rectus is normally functioning, whereas left medial rectus is gone. So the lateral rectus takes the eye towards the opposite side, that is abduction, away from the nose. Now coming to like when you ask the patient to look towards the right side, the patient cannot look towards the right side because right LR is gone, left MR is gone. So both are gone, right LR is gone, left MR is gone. So patient cannot look towards the right side. But when you ask the patient to look towards the left side, he can look towards the left side because abduction movement is normal, because left lateral rectus is normal. But the patient cannot look towards left in the right eye because here you have to have this MR functional, but this MR is gone. So in this way you have to identify the like you have to diagnose the 1.5 syndrome. So when you ask the patient to look in the center, one of the eyes will be in the abducted position in 1.5 syndrome, whereas when you ask the patient to look at the center in the INO patient, they will be in the normal position only. Now when you ask the patient to look towards the right side eye is staying still, it is not moving. That itself should tell you that the lesion is towards the right side. So they are talking about right 1.5 syndrome. When you ask the patient to look towards the left side, since the left LR is normal, the abduction movement occurs, whereas the right eye cannot move at all because both LR and MR are not functioning. So all the three images, in all the three zones, the right eye will be in the center because nowhere LR and MR is functional. Whereas the left eye is in the abducted position normally when they look at the center and when you ask them to look towards the left. So this is how you have to differentiate between 1.5 syndrome and INO. Okay. Now this point about 8.5, this is easy. This is just like mass. 7 plus 1.5 is 8, right? So 7th nerve lesion plus 1.5 syndrome is 8.5, and 15.5 is bilateral 7th nerve. So 2 into 7, that is 14 plus 1.5. 14 plus 1.5 together constitutes 15.5, right? So when bilateral 7th nerve lesion with 1.5 syndrome is seen, that is called as 15.5, and when unilateral 7th nerve lesion with 1.5 is seen, it is called as 8.5 syndrome. So yeah, these are the take home points. This cloud and here this highlighted INO. These are the take home points from this video. I'll provide you the PDF also. So I hope I have made these concepts clear, and thank you. Please support by liking the videos and sharing these videos among your friends so that it will give me a kind of motivation to make more topics easier for you. So I have got your question, guys. So I'll help you solving this question so that the whole topic is consolidated in one single question. So how to solve these kind of questions when you get in the exam. So they are showing you that at the baseline, the position of eyeballs is in the center. So this is the right eyeball, this is the left eyeball. So the position of right and left eyeballs is in the center at the baseline. When you ask the patient to look towards the right side, the movement is normal. So look at here. This is the medial rectus zone and this is the lateral rectus zone, right? Muscles. So when the patient is looking towards the right side, the right lateral rectus is normal and the left medial rectus is normal because the movement is proper only, like it going towards the end. But when you ask the patient to look towards the left side, the right sided eye is in center position. It actually has to move this side, but it is not moving because there is some mistake, there is some lesion or there is some abnormality with this MR. So that indicates that right MR is abnormal. Whereas here look at this, here look at this muscle, that is LR is normal, that is left lateral rectus is normal, and they have already mentioned you that there is a nystagmus seen in this patient in the left eye. So let me write it for you. This is showing right-sided MR lesion, right? MR is for adduction, whereas LR is for abduction. I hope every one of you know these points, that MR is for adduction and LR is for abduction. So there is right-sided adduction weakness because the eyeball is not moving towards this direction, and left-sided abduction is taking place because it is normal. Lateral rectus is normal, so left-sided abduction, nystagmus is seen. So I have told you this sentence in the previous video, that ipsilateral adduction weakness and contralateral abduction weakness is seen in INO, right? So ipsilateral adduction weakness, that means ipsilateral is right here. So right-sided MLF lesion is seen in this image. So your answer will be right MLF lesion. So this is as simple as that. So right MLF causes ipsilateral, meaning right adduction weakness, and contralateral, meaning left abduction nystagmus. I hope this is clear. So INO, the term itself tells that internuclear ophthalmoplegia. Internuclear, meaning between two different nuclei. What are the two different nuclei? One is sixth nucleus and one is third nucleus. Inter meaning in between. So in between there is a tract, that is medial longitudinal fasciculus, which connects the one-sided sixth nucleus to the other sided third nucleus. So it is named on the direction of the fibers which it is taking, that is, this is left MLF. In this question, the answer is right MLF because you are seeing the nystagmus on the left side and the right-sided adduction weakness is same. So this is how you need to solve the questions from this topic, guys. So if you find any topic or any question you find difficult, please post on the Telegram channel. The links to the Telegram channel are provided in the description below. And